5, 4, 3, 2. Good morning, everybody. This is Dr. Zach Baker. You are listening to the Strength in Knowledge podcast. And today we have with us a special guest who I'm very excited to have on. We have Dr. Robin West, who is a local orthopedic in the Northern Virginia area, and somebody that we've had the fortunate ability to interact with and share some mutual patients with at our Southern Montgomery County locations, our Northern Virginia locations. She's a local orthopedic surgeon. We're going to talk today a little bit about ACL rehab, which is one of her passions and one of her special interest area of expertise. But Dr. West, I will let you do a little bit more in-depth introduction of who you are, some of the various roles and titles that you carry, and what you've done to get to that spot, because you're doing some very interesting and some very awesome things within your career currently. So thank you for coming on.
Thanks so much for having me, Zach. I really appreciate it. So I'm an orthopedic surgeon. I specialize in sports medicine, so I'm board certified in both orthopedic surgery and sports medicine. I spent the first 12 years of my career at the University of Pittsburgh, where I served as faculty member. So I taught the residents, the medical students, and the orthopedic sports medicine fellows there. I was also a team physician at the University of Pittsburgh, Carnegie Mellon University, and then I've served for 17 years as a team physician in the NFL, 12 years with the Steelers, and then 5 years with the Commanders. So back in 2014, I came to Inova in Northern Virginia. They recruited me to come and build their sports medicine program. So it was an interesting opportunity. I love my career in Pittsburgh. I had a great job there. But this was an interesting opportunity kind of midway through my career and thinking, maybe I can make a change and to build something from the ground up. So I came here in 2014 to build the sports medicine program, really starting at ground zero. And then I took on an additional role as the president of the musculoskeletal service line for Inova. So in this role, I also oversee the 200 plus orthopedic surgeons, the 400 plus physical therapists, as well as the PM&R physicians and the podiatrists. So it's a big role. I do that in addition to my clinical role as a surgeon and seeing patients. And I've been taking care of the Commanders the Nationals for the past 8 years. And then my team, again, we've built this incredible team, multidisciplinary team of primary care physicians, orthopedic surgeons, physical therapists, athletic trainers. And we take care of DC United, Washington Spirit, DC Defenders, as well as a lot of local colleges and high schools. So that's my role. And so thanks for having me.
Now, again, thanks for coming on with all of those different roles. The fact that you were able to squeeze this in means a lot to me. And it's remarkable to hear all of that. I have some similarities with you in regards to I wear several different hats, some involving clinical care, some involving just oversight of clinical operations and the administrative side of things. I also do some teaching at 4 different physical therapy programs and do some external education from a Con Ed standpoint. But I look at all of that, and it's not nearly at the scale of what you've done. And I know some of the struggles and challenges that I see overseeing, 65 PTs across 11 locations, interacting with individuals that are multidisciplinary in nature when we talk about some of the educational initiatives we have and the different seminars that we run. So when I hear all of the different things that you are doing, I can empathize with some of the challenges and struggles that you have just logistically trying to get it all to fit, but also just extremely appreciative of the scale that you operate at and the high stakes environments as well. It's one thing to be involved in sports. It's another thing to be involved in pro sports and then to navigate pro sports across multiple professional organizations. They all pose some of their unique challenges, and I think we'll touch a little bit more onto that later. But to kind of redirect ACL rehab, that's admittedly how I first came across your name as a physical therapist in the greater Maryland, DC, Northern Virginia area. Your name is extremely well known in our area for somebody who does a lot of ACL surgeries and does them very, very well. This is obviously a special interest and area of expertise for you. Would you mind touching a little bit just over the last 5 to 10 years? What is one advancement in the ACL surgery area that you have seen? And whether it's surgical, rehab, community awareness, what is one positive trend that you have seen recently?
Gosh, well, I think there's been so much. I mean, it's such a vast area. And if you look at, the surgical, the surgical aspect, the aspect that I'm really involved in, right? I have a very small part in the role. But the surgical aspect, the techniques have really changed tremendously. The implants, the guides, the camera system, everything has really improved and has made our surgery much easier for us to provide the best care. So that's the surgical side. I'd say the rehabilitation side, what I've seen over the past 5 to 10 years, and you can go into certainly more detail, but I've seen that the therapists are much more knowledgeable in general. Obviously, this is very it depends on the location you're in, but in general, I think that there's a lot more knowledge around the rehabilitation process, specifically of ACLs, and looking at true outcomes and not just the failure rate. When I came out of residency 20 plus years ago, that ACLs were touted as, hey, it's a great surgery. 90% of people do well and don't fail. But really looking at the failure rate and the return to play rate, we started looking at those numbers specifically and saying, gosh, there's only a 65% return to play rate in these professional and high school athletes. And why is that? Again, maybe they're not failing, but are they getting back to the things they love doing? And so I think looking at those true outcomes has really opened our eyes to try and optimize the care, surgical as well as the rehabilitative side.
I'm glad you touched on that with the difference between having a re-tear and having a successful outcome. And they're not necessarily synonymous. And like you said, just because somebody doesn't re-tear, I mean, that's great. But if they don't go back to doing the things that caused them to have the injury in the first place, we're kind of just masking the situation. And I think on a rehab side of things, the biggest change that I have seen over the last 12 years that I've been practicing is honestly the level of accountability within the rehab profession. And I think because ACLs have always been a relatively common and higher incidence injury, I think that was often mistaken on our end as an easy thing to rehab because we saw it so many times. And then the data started coming out, and we started to realize that a lot of these people who are having ACL surgery, they're having it a second time, and they're going back to sport, and they are not adequately prepared to do so, and it's leading to a re-injury of the already involved side or the contralateral limb. And I think that was really a time for reflection in the rehab field, and it forced us to be a little bit more data-driven and a little bit more intentional with what is our criteria with individuals returning to play, like you had alluded to. And what are some specific outcomes that we are looking at locally at the knee? And if we're looking at just some of the physical metrics that we can quantify with regards to strength and torque and output locally at the knee, but then also from a more systemic standpoint. And are we really being intentional with controlling that return to play continuum, having some degree of structure with that, some degree of intentionality? And then also, I think where a lot of the research has gone recently is it was great to develop limb symmetry. Now we just need to make sure that we don't have two symmetrical limbs that are both performing poorly. And I think that's led to PTs needing to cooperate and collaborate with strength and conditioning staff and making sure that they're not overall deconditioned and that they have appropriate aerobic and anaerobic abilities to get back onto the field, perform well, and with the lowest injury risk profile. And that kind of leads me to the next question I have for you is you perform the surgery and then you get to see the individuals come back for their various follow-up appointments. I'm sure some of your higher profile athletes, you're obviously tracking later through their career as well. What are some common struggles that you see with the ACL rehab process with patients? And whether that's early phase or later phase, what have been some common shortcomings you've seen?
Yeah, Zach. I mean, those are all great points, and again, I think it's really important to remember that this is a team effort, right? I always tell the patient I have a small part in the process. I do the surgery, and then they have to then put the effort in, and they're going to work tremendously with the physical therapists and the strength and conditioning coaches, and it's a team effort to get this athlete back to the highest level of performance. So that's really important. But the struggles that I see, I see a variety, and again, it's so dependent on who they're working with their physical therapist, and also on their attitude as well. So I think that the most common thing I see, and I actually just saw someone yesterday in my office who's 2 weeks out from her ACL. And pre-op, I always stress the importance of gaining that heel pop, right? That's the first thing I want them to get. And I want them to get that basically in the PACU, in the recovery room. So right after surgery, I'm having them show me that they can do that. They can do a leg raise, and that they can get that activated. And I'll show them that they're doing that day 1, day 2 before they start physical therapy. And then hopefully starting therapy within that first 2 days after surgery. But I had a patient yesterday who was doing all that pre-op. She was very educated, was really willing and very motivated. And I had her come in yesterday for a 2-week visit, and she wasn't able to do it. And I asked her why not. She was doing it right after surgery. She had texted me like a week after she was doing it, and she said her physical therapist told her to stop doing it. That was really not the goal. That the goal was to get 0 degrees of extension. She had about 8 degrees of hyperextension on the other side, and this physical therapist said, you don't want to get that back. You want to just stay neutral, because you don't want to increase the risk of an ACL tear. And so I think that, that lack of active terminal extension is probably the biggest thing I see and early on. And I really think that's important to stress to get back to the athletes. And you can talk more about that as well, but patients are not happy when they can't get it back. They have trouble activating their quad. Overall, their performance, biomechanical performance is affected when they can't get that active terminal hyperextension. And then I think the other struggle I see is also that there's no focus on overall biomechanics. I have these patients at 6, 8 months out after surgery. Again, in my office, I'm just doing a basic exam. I'm looking for an infusion, range of motion, stability, maybe a single leg squat, double leg squat, whatever I can do in my office. I'm not doing any kind of performance testing. But even just simple, single leg squat, and I see them weakness and collapse, and that's a concern again, because they say, oh yeah, this physical therapist, no one's ever focused on that. And so I just want, again, to reiterate the importance of the overall biomechanics. And then finally, I think the other struggle that I see is the mental aspect, right? Is the mental recovery. And I try to catch that early. I talk to my patients initially on that day of injury or that week of injury when I see them, and getting them ready for this process of recovery, and trying to get them early if they need to see somebody, need to see a sports psychologist or a mental therapist, whoever it is. And so I think that's also, since the physical therapists are spending the most amount of time with them, just trying to identify those patients who may need a little extra help. It's a physical and mental recovery.
Absolutely. And on our end, from the rehab side, one thing that we implement at our facility, and I think you're seeing growing more across the rehab field, is the utilization of different subjective scales, such as the ACL RSI or some of your other psychological readiness scales, that is really bringing to light some of these individuals that look great on paper. Their range of motion looks good, their strength looks good, their movement mechanics look well, but they don't want to go back to practice. They're afraid to go back on the field, and we've captured some of that through these different questionnaires that we typically implement early on, and then we, every time we do a progress note with them, we have them fill it out again, and that has been very beneficial on our part, where when they go back to see you or the other surgeons they're working with, we can communicate that to them or communicate to the patient, hey, we may need to tag in another healthcare professional to tackle this aspect of why they are not psychologically ready to return to play. And I love the fact that you had mentioned educating the patients preoperatively and setting the expectation for what they need to do immediately after surgery prior to that first PT session. And I like to think that our patients trust us at our facilities. But I can tell you 9 times out of 10, what the surgeon says to the patient is going to trump whatever we say. So when they hear a surgeon telling them, hey, you need to get that heel pop, you need to get that quad going, you need to get that knee extended, it makes our job a lot easier because they've already been given that permission to start working. They've already been given that permission to start feeling athletic again and start the rehab process. And they're not wondering, am I going to harm something? Is this going to be detrimental? This is relatively challenging. There might be a slight degree of discomfort associated with it. When they've had that peace of mind from the surgical team saying, yes, you need to do this, it's necessary, it puts us on the rehab side in a much more favorable position with these individuals. And you had alluded to, we need to carry over these early phase victories and make sure in middle and late phase it's translating to proper biomechanics and proper movement. And we always talk about, we want to make sure that we have good movement in isolation. Then we want to make sure that we can integrate it into more functional movement patterns, into more compound movement patterns. And when people are 3, 4, 5, 6 months out and they're demonstrating dynamic knee valgus, it makes it easier as a clinician to figure out what is the cause of that knee valgus, or what are the influencing factors. And if this is somebody who struggles with ankle dorsiflexion, or they struggle with eccentric knee extension strength, if we haven't checked off those boxes early, we can almost go and guarantee that they're going to have some sort of movement abnormalities at later phases because they don't have the parts and the pieces to even do basic things well. If we've done our due diligence of checking off all these basic orthopedic impairments early on, we ensure that they have quality strength. We ensure that they have optimal range of motion. We've minimized the amount of fear avoidance and some of these other potentially psychological factors, and they're still moving poorly. That's when it's on us to, one, bring it to their attention. Hey, did you realize you were moving this way? And there's not a reason to move that way. You don't have to move that way because you have good range of motion, you have good strength. And then we can work more on that neuromuscular re-ed, the body awareness, more of the positional control. And I think the biggest thing that I have seen throughout my career is the PTs that are good at doing that are the ones that have done the early phase rehab well, because they're not guessing at why this person is moving a certain way. They've allowed themselves to minimize the potential influencing factors. And that kind of goes into the next segment where ACL research, it's come a long way. And we've seen a variety of different things come out with regards to return to sport testing, return to sport risk factors. I know neurocognitive rehab and the integration of that is becoming really the hot topic over the last few years. But is there an area of ACL research that you would like to see explored further? Or is there something that you kind of view as the next window of opportunity for ACL rehab, either from a surgical lens or a rehab standpoint?
Yeah, Zach, I think that, again, those points you made about that early, mid, and late phase rehab is so important. And so you can't reiterate that enough. I always go back to that study out of Mayo Clinic. It was probably maybe 5-7 years ago, but it looked at female high school soccer players, which is probably our most common athlete, right, that we see with ACL and ACL injury, these female athletes in general. But there's a 28% chance of an ipsilateral or contralateral ACL tear within the first 2 years after that first injury. So I always talk to my patients about that, and we want to do everything we can to mitigate that risk. And so, again, we've done tons of research around it. What are the risk factors? How do we eliminate those? Some of them are modifiable, and some of them are not modifiable. Right, the tibial slope, maybe we can modify that, but we can't modify the narrow notch or maybe some anatomic valgus alignment, but the neuromuscular stuff we can modify. So I think those are really important. But talking about the research going forward, again, I think it's all fascinating. I mean, I'm intrigued by all of it because we're looking to maximize these patients' outcomes, get them back to play, return to play at the previous level, and obviously the risk of not injuring themselves again. But something that's often been brushed off and has not been studied a ton is really the mitigation of the degenerative changes, right? So we know there's a high risk of getting arthritis after an ACL injury, probably from the initial injury itself, from the impact itself, the bone bruise that you see, the bone bruise pattern. So we know that within the first 10 years, the majority of patients are going to get pretty significant degenerative changes. But when we're taking care of these young athletes, how do we mitigate that risk? And, is it rehab? Is it, eliminating high impact stuff? Is it decreasing the effusions, aspirating the effusion so they don't have this bloody hemarthrosis in their knee, right? With all these toxic factors. Is it our surgical technique? And I think we've modified and really optimized our surgical technique in doing these anatomic ACLs. And Dr. Fu was really big into that double bundle reconstruction. And maybe that's not the right answer, but really it brought it to light, making this ACL more anatomic and using the best graft that we can. So I think that on the forefront, really going forward, the research I'd like to see explored more is that degenerative process. What can we do to optimize recovery all around and not just give them a good knee in the short term, but the long-term results?
No, that's interesting. And that is another example of something that's extremely multifactorial and kind of the educational component of that falls on a variety of different people. And you alluded to the surgical choice, the surgical technique, maybe something that can influence what that looks like afterwards. Are there some immediate things that can be done, whether regards to aspirating the joint or other procedures in that acute phase or following surgery? And then I think some of the other modifiable factors that we have is also recognition on a rehab side of things of who are we dealing with? Is this a 15-year-old high school athlete who's going to have a high school and collegiate career ahead of them and potentially beyond that? And maybe they're a field or a court sport athlete where the knee is going to go through a heavy demand in the upcoming years? Or is this a recreational adult who had kind of a fluky injury and they don't have a definitive activity that they need to go back to? And what can we do from a rehab standpoint to educate them on what is your goal of being physically active? And what are our options for being physically active? And can we help point them in the right direction of activities that may be friendlier for that knee joint? And if we're trying to minimize some of the degenerative changes that happen, we may be able to steer them in the right direction of what does being healthy from a lifelong standpoint look like, and what's going to put us in the best position for success from a strength training, from an aerobic and a cardiovascular standpoint. What are the different risk rewards of all these different exercises? And it's funny, I tell my patients, if you want to increase your aerobic fitness, your muscles, your heart, your lungs, they don't know if you're running, swimming, biking. They just know that there's a physical demand that they need to exceed. So if we can find a demand that also decreases the amount of mechanical load and mechanical stress on some of our orthopedic considerations, that may be dually beneficial from a variety of fronts. Last question for you, Dr. West, and this is one that I'm kind of excited to hear your answer. You have the opportunity to work with a variety of populations, ranging from youth, adolescent, recreational athletes, all the way up to some of the elite professional athletes. They all pose some of their own unique challenges and situations and scenarios. What are some of these different challenges that you see in these different settings?
Yeah, it's a great question, Zach. I mean, it's very challenging across all the different level athletes, right? So I think number one is access to physical therapy, to good physical therapy, right? And that can be based on economic status of the patient. That can be based on geographical, like where are they located? How easy is it for them to get to PT? And also in insurance. Insurance often approves 20 visits, which makes me crazy. So I see a lot of patients where at 3 months, they're like, oh, I'm done with PT. And so I think that's always a fight. And again, that's not at the professional athlete level, but that's at our high school athletes. And that they're the ones who are struggling. And so trying to do the best we can with what they have and what they have access to. I think that communication is often difficult. Again, I love getting messages. I give my cell phone to most of my patients. and to the physical therapist, because I do want to hear. I want to hear what's going on with the patients. Is somebody at 2 weeks out? Is something going on? Is there a concern? And at 6 months out, is there a concern? Do they have any issues? Again, because we want to be in communication. What are my goals? What are their goals? And the patient's goals. It's a team approach. So I think that lack of communication, again, on the professional side, it's a lot easier because you're working with a team. But again, on the high school side, and so, and I think that on the professional side and the collegiate side, what I see is the goals are often not the same, right? The athletic trainers, the coaches, the physical therapists, the family members may have different goals. And so trying to get on the same page with everyone and really to educate everybody. Like, this is a big recovery. This is a minimum of 9 months, and you're probably looking at 12-month overall recovery. And so, and to educate everybody to be on the same page. So I think that with the professional athletes, it's easier, again, because of the team approach. You've got everyone working together with this person, the chiropractor, as well as the physical therapist, the athletic trainers, sports psychologists. And the challenge is, again, working with the agents, the communication. The agents don't always have always have the best recommending, what's the best for the patient as far as their medical care. And they often will pick where they want to go based on some financial aspect or, so I think that's just making sure that patient's being treated appropriately. And then the collegiate athlete, I think the collegiate athlete in the past couple of years, the hardest thing has really been the transfer portal, right? We operate on somebody and all of a sudden they're gone. They're no longer with us. They're now across the country at a different school. And so again, now we're dealing with communication, documentation. How do we document these things now? We're documenting it in our medical records, but then is it going to get transferred with them in the transfer portal? It often doesn't. And so trying to then talk to the team physician about that athlete, and then again, just losing that connection with them. And then the final thing is when the athlete transfers, how do you follow up with them? Maybe you were seeing them in person before. Can you do video visits with them? Which is good and bad, right? So you're not able to touch and examine the patient, but you need to then rely on their new team taking care of them. So I think that the biggest challenge is overall setting these goals, and it's variable throughout the recreational and to elite professional athletes.
Communication is the common theme that I hear through all of that, and I can echo a lot of the sentiments that you just displayed. It's funny, prior to getting onto this, I was emailing with Cornell University regarding a men's soccer player that we're working with, and just trying to get them data. It was somebody that came in, did some baseline testing with us over the summer, utilizing our force plates. So we had a lot of healthy baseline data for them, which worked out well because unfortunately this athlete had an injury this fall, and we were able to give them some of that preseason baseline data so that they had some sort of normative values for them to get back to. But again, if that was not initiated by the athlete, by the athletic trainer, we would not have been able to utilize that. I did one of my clinical rotations in school out in Phoenix at a facility. The owner of the facility was the director of sports medicine for the Arizona Cardinals. They had a heavy NFL and MLB off-season training program there, and they had a lot of pro athletes that came in for care. And it was always interesting being there because it was a private facility. So even though these athletes had access to wherever they were from a professional sports organization, they were electing to go to this private facility for their rehab or for their off-season training. And that poses a lot of challenges because you know what you're doing within your four walls with that athlete, but you don't know what the athlete's doing when they go back to the team facility. And you don't know if they are sneaking in another workout or if it has been communicated to the medical staff there what you did with them. And you have to do a lot of due diligence to make sure that you are not over or under programming for this individual and making sure that all involved parties have the same information at play. And then obviously all of the external conflicts that come in. It's one thing to work with a high school athlete who is playing high school sports, and that's the peak of their athletic career. It's another thing to be working with a professional athlete who is finishing their final year of their rookie deal. They have ACL surgery. The next season is starting in 8 months, and they're trying to figure out, what do I do? Do I push this rehab process and try to get back and lock in that next big contract? What are the risk factors of doing that if I re-tear and I have 2 consecutive seasons that I miss? Am I a college athlete who has scholarships on the line, or I'm in the recruiting process as a high school athlete? So I love how you talked about, there's the X's and O's of how you do the surgery and how we do the rehab, but none of that matters if the patient and all of the supporting staff is not bought in and everybody's on the same page with that. Dr. West, I appreciate your time. It was very fascinating just hearing your inputs on all of this. It's also very reaffirming to see on my end as a clinical rehab PT that a lot of the conversations I'm having with my patients are mirroring what you're having with them as well. So I think as our 2 professions, that bodes well and moves that we are moving in the right direction as sports medicine providers. I appreciate your time. If anybody is interested in just kind of following along with what you're doing from a professional standpoint, is there any way that they can keep in touch with you or just follow along superficially with what you're getting into?
Yeah, I'm not a big social media person, but I do have Instagram, Facebook, and I also have a web page, Robin West. You can just Google it and it will come up. But so I've got some information on there, some educational stuff, some articles and research I've done. But I really appreciate you, Zach, and all the therapists that I work with. And I learned so much from you guys. Again, we have a very small niche that we take care of as far as the surgical side. So you play a huge part, and I really appreciate your education in doing this podcast and helping to educate everyone else. So thank you so much for having me.
Absolutely. For those listening, this is the Strength and Knowledge Podcast. If you enjoyed this episode, please share, like, and subscribe, and stay tuned for next episode.